Okay, so this section is going to focus primarily on ACL injuries, which you can tell by the prevalence graph is not the most common injury, but it is debilitating in terms of sports play, so it gets a lot of attention. This is an MRI cut through the middle of the knee joint, so this is right in the intercondylar notch, and it emphasizes the attachment points of the ACL. So the ACL really runs through the intercondylar notch from um, lateral in the notch to medial on the tibia. And this midline, you can see the patella here, the cartilage, just some of the femoral condyle cartilage in the lateral side. This is mostly the intercondylar notch. And we can see the ACL here in black running through that notch. And this line of action helps us understand that the tibial anterior translation is blocked by the ACL. Now, how do people injure themselves? Well, usually ACL injuries are almost 100% sport specific, so they occur in a very young population of people. Most are associated with sports, and most are associated with non-contact injuries. The number of reconstruction, this is an old statistic, but it's not the most dominant injury, and then it costs around $20,000 per year. The ratio of female to male injuries has quite marked differences in some sports and not others. You can see here for wrestling, basketball, soccer, both kinds, rugby, should be rugby, not rigby. There's definitely a bias toward females being injured more frequently than males, but when you get to lacrosse or alpine skiing, the ratios are the same. So this is a study using the robotic knee. It's that where they imposed motion on a robotic knee and then tested the strains in the ACL and MCL and the bone during these different motions. So you can see here what this is trying to show in this diagram is if you have an anterior translation, the primary restraint is the ACL, and then the secondary restraint here, it's shown as the stretch in the MCL as you translate anteriorly. And so this graph here is recording the force in each subsequent tissue, the ACL in blue, the MCL in red, and bone in white at different knee angles in an in vivo robotic loading test where the robot actually bends the knee in these different positions. What you can see is that the force in the ACL to restrain an anterior drawer goes up around 15 degrees and then declines as you move toward 60 degrees. The role of the PCL or the MCL in bone is fairly low at 0 degrees, but then increases a little bit to 30 and then kind of plateaus out at 60. So one of the problems with the anterior drawer test, which was early, is it was done around 60 degrees, and we can see here that the ACL is not playing as big of a role, and that the MCL role has increased. Well, if the ACL is gone, then what happens is as you translate more, the MCL is recruited, and then that gives you a false negative test. And so the anterior drawer test is really a not very good test for testing the ACL. But the Lachman's test, which tests anterior drawer laxity at around 15 to 20 degrees, is a good test. It keeps the MCL relative slack, and it's where the force in the ACL is highest in terms of restraining anterior translation. Now, there's another thing on the horizon that's already, another surgery on the horizon that's already started being used. If we look at the actual anatomy of the ACL, it actually has two bundles, an anteromedial bundle here and a posterolateral bundle here. And the most surgeries currently, the traditional surgery only replaces the anteromedial bundle, and now a double bundle surgery will be doing both the anterior medial and the posterolateral bundle. One of the significances of the two different bundles is because of their fiber alignment, the anteromedial bundle is thought to play a bigger role in anterior instability, while the posterolateral bundle may help prevent pivot shift or a rotational instability associated with knee extension. Another way of understanding the ACL is to look at how it crosses the PCL from a flex knee position. So this is a straight-on flex knee position from Netter and based on a study by Markov in 1995, where you really can see this kind of lateral to medial angulation of the ACL, and so therefore you can understand both its resistance of anterior translation, but it also gets taught with internal rotation. Now, the most common mechanisms of injury it doesn't seem to be internal rotation, but rather is abduction or valgus and external rotation. And so this is a little bit contrary to the alignment. And there's a study by Zhang et al., Clinical Biomechanics 2003, that sheds some light on this, where they put pressure transducers in here on the lateral femoral condyle and measured the contact pressures between the ACL and the lateral condyle with external rotation and valgus. And what they found is there's a cam effect. As you move the knee into external rotation and valgus, you stretch the ligament over the lateral femoral condyle, and that may be why that particular mechanism ruptures the ACL. Now, we can use this skiing example to kind of motivate some mechanisms that cut across different athletic activities. And essentially here what we're saying is that when the person kind of falls backwards, so there's a larger quad force acting and spins the ski into knee external rotation, that could result in the combination of anterior shear, external rotation, and valgus that would cause an ACL injury. On the contrary, you can have a purely sagittal plane load where the person is also leaning back too far and the skis land too vertical, and then the tibia is cammed forward with a large quadriceps contraction that would cause that anterior translation and rupture the ACL. So 3 mechanisms of ACL injury: excessive anterior shear load, as the example of skiing, adduction, internal rotation, and flexion, which is less common. The most common is abduction, external rotation, near 30 degrees of flexion. Okay, and just note that most of these non-contact ACL injuries have to do with a variety of tasks. So landing from a jump, planning and pivoting, decelerating constitute 81% of all the non-contact injuries. Going up from a jump, just a few, hyperextension a few, and then some are unclear. This is another sample, the same thing, kind of reporting of how people injure themselves, twisting and non-contact hyperextension. Here in this case was 50%, anterior below the knee 50%, valgus force knee 7%. So the data is not always consistent, as we can see in these 2 examples, but most people kind of are confident in this 80% of the injuries being associated with some kind of landing, pivoting, deceleration maneuver. So that's a quick overview of ACL injury mechanisms and how they occur.